Welcome and thank you for joining us in the session Patient Engagement in Research, Regulation and UHC Economics in the Region, moderated by Professor Indrani Gupta, Head of the Health Policy Research Unit at the Institute of Economic Growth.
Thank you. Very good afternoon to all the guests, panelists and participants to this session. I'm really grateful to the organizers for giving me this opportunity to moderate this session, which is on patient engagement in research, regulation, and health finance, building back a better and sustainable UHC 2030. We have three very eminent speakers today, and I'm going to introduce each one of them, and I'm very happy to see many of them again. But I would like to give a very brief introduction to this session before I do that. So we know that in the Declaration of Alma-Ata in 1978, member states had agreed that community participation was a fundamental component of primary health care. Engagement and empowerment of health service users and community members re-emerged as a core strategy in the WHO framework on integrated people-centered health services, which was formally adopted by member states in 2016. So the concept of people-centered healthcare in the region got a fillip when member states in the Asia-Pacific affirmed the political declaration of the high-level meeting on UHC, Moving Together to Build a Healthier World 2019. So it has been realized for a while now that achieving UHC and SDG requires health systems to shift from an almost exclusively vertical top-down paradigm to one that places people at the center of health services. The COVID era has once again made us realize how interconnected we all are. We have seen how providers, nurses, and other health workers have become patients themselves, how bureaucrats, politicians, policymakers have crossed the line from being non-patients to patients. Of course, this is hardly new. Anyone has been patients in some time or another, but the uncertainty and risk in the COVID era has been unparalleled. Community prevention, treatment, vaccine, and socioeconomic impact, these have reminded us again the interconnectedness of communities with sectors, regions, and countries. The need for a better understanding of why, how, who, where of the disease, and how much in terms of financing requires cooperation and collaboration of multiple stakeholders, yes, but at the heart of such efforts remain the affected communities who are the key that would enable us to answer these various questions. Efficient and equitable policies can only be made with maximum information, which can only happen with constant and sustainable give and take between communities and other stakeholders. Health research becomes a key, and as a researcher, I would really want to emphasize that. It helps us understand what works, to what extent, why, and for whom. Not only do governments benefit, but industry that is engaged in health products and services also need to understand this. So research is critical for informing policy in any sector, but especially in the health sector. A very important aspect of being patient-centric or integrating community engagement in UHC is proper funding. So finances play a critical role, and there has to be transparency and accountability as well. So if member states can set up UHC in a way that community engagement via research, advocacy, and participation become the central plank of policymaking, it could possibly push the health sector from being a dispassionate transaction-based entity that thrives on asymmetric information to one that makes every effort to use information to turn the sector into a people-centric responsive one. So with these words, I would like to invite a first panelist, Dr. Sumila Takti, who is the Vice President and Head R&D Solutions India, IQVIA. Sunila is an industry leader with significant experience in clinical research, operations, business management, and policy advocacy with over 25 years stint in the biopharma industry. She is responsible for managing IQVIA's clinical development business in India to achieve business financials, exceed customer expectations, and ensure employee engagement and retention. She has worked extensively to establish clinical research in India and has led policy advocacy for clinical research in the country as well. She has been the president of the Indian Society for Clinical Research, a professional body that represents the interests of all stakeholders of clinical research in India for 2 terms. She is also an active member of the clinical research pharma committees of several industry associations like the CII, EFICI, Organization of Pharmaceutical Producers of India, etc. As a recognition of Sumila's contribution to clinical research sector in India, she has been honored by Healthcare Businesswomen's Association UHC as Healthcare Luminary in 2017, and congratulations for that, Sumila, and by the Indian Society for Clinical Research by a Lifetime Achievement Award in 2019. And she has been quoted by various health media and general press as a key opinion leader. So over to you, Sulila, and you've got 10 minutes to present your side of the arguments. Over
Sure.
to
Thank you so much. Thank you for that kind introduction. And before I begin, I want to thank you, Professor Indrani, and the organizers for an opportunity to share my thoughts here. Something that's very close to my heart always, because we talk so much about medical advances, research, drug development, innovation, but nobody thinks that who is really at the center of all this. When one thinks of all these aspects, the drug development, clinical research, innovation, these are all typically looked at as scientific advances. And when one thinks of stakeholders of such any research, whether it's clinical research or medical research, immediately the thought comes about as to who is going to sponsor this. So mostly it's the pharma company or other association who funds the research. Then there are organizations who specialize in conducting the overall research projects. So there are clinical research organizations or contract research organizations, and their job is to make sure that the timeline, the budget, the ethical aspects, the regulatory aspects, etc., are taken care of. Then there are medical experts, there are biostatisticians who actually conduct the research, who draw up various protocols according to which the research should happen. Also, there are regulatory bodies who set the boundaries within which all the above players should operate, and whose job is to ensure overall societal well-being, such that no harm is brought to the people at large while research takes place. But in all this, one key stakeholder who ideally is at the heart of this whole endeavor is forgotten, and that is the patient. Primary aim of any medical research is to serve the patients with unmet medical needs. But do we know if voice of this important stakeholder is heard, either when policies are being shaped, or whether there are platforms where patients and patient groups can take their issues? In a country when society argues, there are always arguments made in favor of research or against research. How important do various parties think that it's important to hear also the opinion of patient and patient bodies? So these are all the questions, I think, which need much attention and a lot of debate. Let me illustrate this further with taking India as an example, the country where I have done all of my work in terms of establishing clinical research. So if you look at India today, I mean, everybody knows India has a population 1.3 billion people, but we have 16% of global population. But if you look at disease burden, it's not 16%, it's 20%. So it's disproportionate, right? But when you look at India's contribution or India's participation in global clinical research, this research that happens for development of new drugs, new diagnostic techniques, new medical interventions, it is less than 1.5%. So you see the wide gap that we need to address here. Moreover, if you look at India's disease burden, it's unique in the sense it's a triple disease burden. India, as we all know, is a developing economy. So we see the typical diseases of developing economy, such as the tuberculosis, the nutritional disorders, diseases pertaining to childbirth, etc., etc. But what we also see is there is a greater surge in diseases which are typical of a developed economy, predominantly due to the socio-economic transformation that we see in the country and the constant rural to urban movement. And then we have emerging diseases, and there can be no better example here than the current pandemic. However, even when we look deeply into that 1.5% research that happens in India, and we look at which therapy areas this research is happening, who is doing this research, what is being considered, it is not really characteristic of our triple disease burden as a country. And this is because the voice of the patient is not as prominent as it should be. As a result, we do not have a clinical research agenda of our own as a country, and we are completely dependent on Western countries for addressing our unmet medical needs in terms of innovation, not so much into day-to-day taking care of patients, I think there, we are one of the, very good examples. But when we look at unmet needs, when we look at innovations, there's a lot to be driven, and that can only be driven when the patient voice becomes more prominent. And we therefore need patients, patient groups, and patient advocates to come forward and ask for research framework where responsible and ethical research is encouraged. And this is especially important given that not just in India, but everywhere else in the world, we probably, if you look at next 2 decades, we would have 1 in every 5 individuals suffering from an unmet medical need. If you look at indications such as rare diseases, for many of them, even the diagnosis is a challenge. So forget about the treatment, where we are still struggling with many diseases where we are also not yet there in terms of the correct diagnosis. So these are the questions. And while all the medical angle, the data angle, the statistical angle is important, the ethical angle is extremely important as well. And that's where I feel the patient groups, patient bodies, and individual patients are absolutely well placed to kind of drive. And this is something I have experienced as I have done a significant advocacy in India for clinical research. I wouldn't have been able to do it without some very active patients and patient bodies. So I will leave these thoughts for further discussions and questions, and hand over back to you, Dr. Indrani. Thank you so much.
Thank you, Dr. Sumila. That was very interesting, and I'm sure our participants will have a lot of questions for you because clinical research is so much in news these days. So with that, I turn to our next speaker, Dr. Chandrakant Laharia, who is the National Professional Officer of UHC at the WHO India office. Dr. Laharia is a medical doctor and public policy and health systems expert. He joined the WHO in early 2008 and has been engaged in WHO's work on immunization program, health system strengthening, as well as UHC. Over these years, he has been engaged in drafting of a number of policies and programs, including the National Health Policy 2017 and launch of the Ayushman Bharat, the flagship program of the Indian government, in 2018. He has co-authored a book titled Still We Win, India's Fight Against COVID-19 Pandemic with Dr. Gagandeep Kang and Dr. Randeep Guleria, published by Penguin Random House India in November 2020, which has just happened a few weeks ago. So we want to congratulate Dr. Laharia on his book. And over to you, Chandrakant.
Thank you very much, Professor Indrani Gupta. And thanks everyone for joining. So the topic which I have been assigned is addressing health equity and engagement of underserved communities in national research and decision making. So in my 10 minutes, I would initially reflect upon some aspects of what equity or equality is. Then I'll move to the universal health coverage and primary healthcare agenda and how increasing community participation can help in addressing those inequities. So to start on the first part, we know that equity is absence of avoidable or remediable differences in group of people. And now these differences are defined by various approaches such as socially, economically, demographically, or geographically. When it comes to more of a health inequity, these are the unjust differences in health outcomes between the person of different social groups and can be linked to some of the disadvantage such as poverty, discrimination, or lack of access to health services. What we know, many of us know the inverse care law, which highlight that the need of those people, the people who have the maximum need usually end up with the lowest available services. The availability of services is inversely related to the needs of the people. And that's what the reflection of inequity is. We keep talking about inequity, but not say or talk about inequities in terms of very narrow sense of rich and poor, or in terms of urban and rural, or male and female. These are the common differentiator we use. We know that equity in health or inequity in health has many faces. One of the approach which is commonly used is called progress, where P stands for place of residence, R stands for race or ethnicity, G for gender, another R for religion, then E for education, and then socioeconomic status and social capital and resources. So progress is one of the way to expand the way we look at the inequity, and this is acronym, which I highlighted. But that's not the only thing. In addition to progress, there are additional equity stratifier, which can include lack of civil registration, or also sometimes migrants or refugee status can also result in inequity. So due to inequities, or when population group experience multiple level of disadvantage, for example, somebody has a low education, but also low income or low socio-economic status, it just aggravate the inequities and become even more challenging. What we know that health equity is normative concept, this sort of norm, but cannot be precisely measured. What is measured is inequality. Inequality, the difference between the same populations. And so identifying health inequities can help us to drive or take the measures to achieve health equity. What is required to achieve this, that we need to keep monitoring health inequality on a regular basis. And this can be done through a number of mechanisms. Like, for example, to monitor health equity, we have a health indicators. But to monitor health inequality, we further need another stream of data set, which is a stratifier section. So we need dimensions of inequity or another set of stratifiers. So we need two set of data, and this data can come from broadly three different sources of data. Institutional database, which could be facility record or health information system, but population-based database of census data, vital registration system, and household survey. And in addition to institution and population-based data, we can have a specialized surveillance-based data. So we can, on the availability of these data sources, we can measure either absolute inequity, which is a difference between the best performing group or worst performing group. So if a coverage in particular group, best performing group is, let's say, 80%, and then worst performing is 30%, then the gap or absolute inequity is 50%. But we can have in terms of proportion as a relative inequity. All these can be measured, and in addition, we can also measure the trends in inequality, that how over a period of time inequalities are going on. What is the difference between the top quintiles and bottom quintile? So we need to understand the concept of inequity. We need to understand or keep measuring the inequity. And when we know these two things, then only we can think of addressing inequities in policies and programs. Now, there could be different approaches which can be adopted if we know what is the level of inequities and the inequalities in the population, which is possible by knowing the data. And so all the countries which aims to address inequalities should strengthen their data recording and reporting system. They should use the additional stratifier to understand where the inequalities are lying. And on that basis, the appropriate actions can be done. For example, if we know that who are the excluded and marginalized population who are really left behind, then maybe for them the targeted interventions are required. If the pattern in inequality is incrementally linear, which means like as we go higher in a particular group or socioeconomic strata, it increases, the coverage increases, but even all the population have a limited coverage, then probably we require, or not probably, we require a combination of universal coverage and also targeted intervention toward the people who are in the bottom. And if there is a coverage, there are not that much inequalities, but essentially coverage with the services in that population is relatively low for all the population, then we go for universal coverage or universal actions. In addition to this addressing inequities in the population, what is important that even when countries or setting achieve a fairly good universal coverage and inequities are minimized, our job is not done. We need to monitor, regularly monitor and assess the situation in those settings. Now, one of the integral part of addressing inequities or inequities and inequalities both is that we need to continuously keep engaging with the population groups which are affected by these inequalities. We need to have a research data which can make our point stronger and then factor in all those in a decision-making process. So one of the approach which many countries have slowly started adopting in the recent times, that including the participation of those groups which are affected by inequality in the decision-making process. One of the accepted approach for such mechanism, either you have their representative group in form of civil society organization, or within the programs, we make mechanisms for increased community participation. And that's how those inequalities are regularly understood and addressed. I would like to take an example of India, where over last 15-20 years, under National Rural Health Mission and then under National Health Mission, multiple mechanisms were adopted to increase the participation of the vulnerable and marginalized group in policy making. So the National Rural Health Mission in India is one of the flagship program which focuses on increasing access to healthcare services and addressing inequities. So it has one of the decision-making body, which is called National Mission Steering Group. And now, in addition to the experts, policymakers, this has a representation of civil society group. And that's one approach of how the community participation or the experts who speaks on behalf of those marginalized were included in the decision making. Then the National Health Mission also institutionalized mechanism called Advisory Group on Community Action, where the systematic mechanisms were established to conduct the trainings of community-based organization, to be involved in the program at the grassroots level, to increase the participation of community members in decision making. And number of additional mechanisms were included or started, such as having a community health worker, which is accredited social health activist, village health, sanitation and nutrition committees where Panchayati Raj or elected self-government member participate in those decision making. So these are the mechanisms to address inequity. And then, of course, there are additional mechanisms of conducting social audit, capacity building, and then regularly conducting common review mission, going to the field, assessing those parts. So coming in the broader context of this inequities and community participation, we are at the global level hearing a lot about universal health coverage. Like entire world has committed to universal health coverage or UHC as part of Sustainable Development Goal 3, the target 3.8. And essentially UHC is also about addressing inequities. When something is universal, of course, the idea is addressing inequities and providing services for those who are left behind. So UHC by concept is for all the people need to have access to services, which will focus on addressing inequity. At the same time, we also know the another discussion of health system strengthening. And health systems have a goal. One of the key goals of health system is improving health outcomes and addressing inequities. So the global discourse is, as of now, is on addressing inequities through UHC and SDG and health system strengthening. What we have learned from so many years and from Alma-Ata Declaration and Astana Declaration, that the primary health care is the foundation of achieving universal health coverage. What we also know that one of the core principles of primary health care is community participation, that communities are involved in their decision making. So many of these dialogues and global discourse which are happening, UHC, health system standing, SDG, primary healthcare and community participation, all of those converge. And these are the opportunities that we start focusing upon addressing inequities. And that is possible when we have communities and the people who are involved in this process. That's possible when we understand what inequities are. That's possible when people highlight the importance of inequity. So this kind of dialogues which we are having today will help. We need to focus on inequities. We need to demand for disaggregated data on inequities. And that's how the progress will happen toward universal health coverage. That's both a solution and opportunity to move in this direction. So with these reflections, I'll stop and then maybe I'll go for the questions as and when required. Thank you very much.
Thank you so much, Chandrakant, for an excellent presentation. And I'm so glad you mentioned the inverse care law, which was introduced by Tudor Hart.
Tudor Hart.
Yeah, response to what he thought was a failure of universal health coverage to take care of social inequalities. So I think we'll have to be on our guard, even with UHC, that we actually cover all the groups that you mentioned, and that can only happen through community participation, of course. So I move on to the next speaker, Dr. Eduardo Banson. I have a pleasure to introduce him to all of you. He's an MD, Principal Health Specialist at the Asian Development Bank. He is a health specialist in the Sustainable Development and Climate Change Department of the Asian Development Bank, I qualify. He champions universal health coverage and has long provided technical support on UHC to countries in Asia and the Pacific. Before joining ADB in 2014, he was WHO Regional Advisor for Health Financing for the Eastern Mediterranean region and WHO Health Economist in Bangladesh, President and CEO of the Philippine Health Insurance Corporation, World Bank Senior Health Specialist for the East Asian Pacific region, and a faculty member of the University of the Philippines College of Medicine and Ateneo Graduate School of Business. So over to you, Dr. Eduardo, for your words.
Thanks a lot, Indrani. So I was actually proposing that we remove the slides, but well, it's okay. And I think one of the things, and picking up on UHC, before COVID, okay, when we talk, one of the things among the things UHC was addressing more than inequity is also trying to address what we call uncertainty. So when you start talking about one of the sad things that we have seen, unfortunately, in health systems is that there's always uncertainty whether the particular service is available. So you have stories of countries where you go to a facility and you don't even know whether there's a health worker, there's a medicine, and all that. And if it's available, there's a certainty on financial protection. So it's available, but you have to pay for it. So, or you don't even know you're covered. So what UHC has been trying to address, for me, is both that is removing that uncertainty, so that when you're sick, you know that you could, or when you need healthcare, you need to be managed. It is also designed to address inequity, and to completely agree, the whole logic of UHC really is to shift resources so that it could help those who are in need of that, whether you're poorer, you're more sick, you're older, and all that. Unfortunately, COVID-19 has disrupted that world. What is COVID-19 if you start thinking about it? We're essentially all living with uncertainty right now. We don't even know when COVID-19 would end. We're so afraid right now to go out. And in lots of countries, you have a problem because the health system is already weak by its very nature. This has been compounded. What's even sad is that with COVID-19, global cooperation, which used to be, in a sense, part of strong foundation of UHC and SDGs, have weakened. We hear words like vaccine nationalism, and of course, during the early part of COVID-19, quite sadly, N95 nationalism. Imagine that, right? Countries refusing to sell masks just in case, because they want to make sure that only the face mask will be within their country. Can we have the next slide, please? Sorry. Okay. So what have we seen with COVID-19? Well, really, one of the things we have seen is that countries where there's inequity in the system, weak health system, have really suffered more. Whether we talk about organ care, and this really affects a lot of patients are actually deciding not to seek healthcare services because they're just so afraid that they will get sick of COVID-19 and they will end up intubated in respiratory distress. So we have seen this. Then we have also seen how one of the few interventions that's really been good for the past few months, which is lockdowns, they are very effective against pandemics. They have been very effective in controlling the spread of illnesses. Unfortunately, has very adverse health consequences as well. Of course, we have seen this also in countries where that got swamped with so much patients and they could not manage that. And we have seen how people have been pushed to poverty because of healthcare costs, whether it's the lockdown related, whether you did not get care because the system was swamped, or the foreign care, which led to more complication. So we have seen this. Next slide, please. So, sorry. And really, as countries start to address the challenge of COVID-19, there are more challenges that are emerging. even up to now, sadly, and we really don't have enough effective responses to the pandemic. It's a challenge. A lot of what we think doesn't seem to work in other countries. So it's finding what really works in your context. It's a big challenge. We're seeing, of course, countries with economic contraction, this fiscal contraction would have impact on the financing for health services. We have seen how interconnected the world is, and how this means you cannot solve the problem in your country and expect it to resolve. The vaccine story is an emerging problem, whether we are gonna be working globally together, or again, we'll see this nationalism coming out. And of course, quite sadly, there's like a culture war, countries, people fighting whether you should wear masks or not. We probably will see those same problems with vaccines. People don't even believing scientists anymore, and researchers, and all of. So these are challenges that we need to address. So this is what COVID-19 has given us. Next slide, please. But even as countries are addressing COVID-19, we need to start looking forward. So how would we build back better? What we're hoping is that as we build back better, we need to reflect on these lessons that COVID-19 has caused a lot of our countries. So how can we make sure, and as what I was asked to talk about, health is the heart of building back better countries. So how will we look at health? Well, a traditional way is we start looking at health as a sector, and basically say, as long as we try to fix our health sector, our health system, then that's building back better. An alternative way, which I think a lot of the people listening in this session right now, next slide, probably sees health. Can you have the next slide? Much more than that. That actually, what happened was really because it's, the problem that we have with the pandemic that affected health was really a product of a systematic effect, because it's not just because the health system was weak. There was problems with employment, housing, food, nutrition, transport, all of this contributed. And so if we start looking at health as the heart for building back better, that means we need to look at health outcomes. Now is really a time and opportunity for advocates to start saying, health is a product of investment in so many things. It's not just in the health sector. Next slide. And if we start to look into that and not just say put money into the health sector, but really framing that the problem of health post-pandemic should be societal rather than health sector, then health and all of those interventions that provide that would contribute to improving health outcomes can capture more resources and really makes SDG a reality. So, so we should start talking about interventions that would improve clean air, interventions that would improve transportation, that will minimize injury incidents. I think I could go on and on, but really societal rather than sectoral. I'll stop there, Indrani. Thank you.
Thank you so much, Dr. Eduardo. That was a reminder to us that we need to raise resources, and India is one country where we are doing so badly. And it also, I was thinking that community participation in advocating for more resources is also a very important thing. So it's really, all of us are going to be patients someday. So we need to understand how resources need to be raised and how the resources are being spent. There has to be accountability. So with that, I was wondering, we have about 12 minutes left. Can we open the floor for questions from the participants, from the attendees, and take questions now?
Yes, I will just pass on some of the questions that we have had.
Sure.
From various people. One of the questions that is coming through is, what is the difference between the rural and urban communities now in South Asia? As you know, Asia Pacific has very marked differences between country to country. For instance, in India, you've got over, I think, 60% of the population living in rural settings, whereas in, say, Japan, you have mostly urban settings. So can somebody comment on that? Chair, could you ask the question? Thank you.
All right. I think everyone heard that question, the rural-urban differences. I'm not quite sure whether the question pertains to community participation, patient advocacy in rural and urban areas, or the difference. I guess that's that. So any one of you would like to respond? Sunila, do you want to say anything about your specific area of clinical research? Because there must be stark differences in rural and urban areas in that.
Absolutely. And, typically what we find is, clinical research, I mean, there's a vast difference when you test a drug in a clinical research setting as against, the normal clinical setting. So typically what we tend to do is, for most clinical trials, you need to have the circumstances extremely well controlled. So unfortunately, what we see is that, most research setups are actually confined to urban areas, and you do not see that much of a participation in rural areas, except for the disease that sometimes dictates it. So for example, if it's a research happening in oncology area, many a times the participation in research becomes the only option for the the patient. So we see that they actually come to urban areas for participation. But the exception here is also there are certain large scale community research which need to happen. I mean, nutritional research, for example, or vaccines. Here is where, we need to see the real life settings also. And as we, I mean, if you look at the journey of an asset from, being an invention to being a drug that is at patient's bedside, the tendency is to also collect more and more real life data, because it's one way that a drug can behave in a controlled environment, and a very differently it can behave when it is at the patient's bedside. So while traditionally, research has been more restricted to urban areas, things are changing, and there are ways and means by which we are trying to see how we can get more of that real life experience, real life settings also getting considered. So that's what I would like to say from the clinical research point of view, and others may want to say something else from their perspective. Thank you.
Thank you. Chandrakant, do you want to say something about community?
Yeah, sure. So the first thing we need to remember is that the rural area is not one uniform single entity. We know that the rural Kerala is very different from rural Madhya Pradesh and Bihar. So we need to be mindful of those entities. As far as community participation is concerned, at least I can talk on about India, that the community participation is relatively better, and societies are relatively differently and structured in rural India, and their participation in health services as and when they get the opportunities relatively better than the urban settings. The urban community where everybody is inwardly looking, and then resident welfare association, they are not that much actively participatory in the health services. We also know from other experiences, and as far as ASHA program, the accredited social health activist program, or village health and sanitation committee, that participation of urban residents in health services is sort of very from the distance and not that actively. While there is a lot of opportunity in the rural area, if given the opportunity to the rural people, they would definitely do a very good job for selecting and delivering and planning health services for themselves. And we need to create opportunities. So there are differences, and these differences exist among states also. Thanks.
Thanks a lot. Thank you. Dr. Semi, do you want to take the next?
Yes, there's one more. This is really with regard to when you have a country in various levels of insecurity. By this, I suppose they mean some civil disorders or secessionist movements. I don't know if it's from Philippines or where it's coming from, or even some other area. Does that impact on how you gather data, research data? I think it's something from Afghanistan as well, the attack on polio workers or something. Can anyone comment on that when you have insecurity? Does that impact?
It's a global question, Dr. Eduardo.
Yes, global, yeah.
Yeah. No. So basically, look, the health workers being attacked, of course, is something we don't like. Okay, but we know it has happened. I think the polio story is a Pakistan story, which partly driven by actions outside of the health sector. And I think one of the lessons we've seen there is that if health workers are used to be partial to one of the sides, then that affects everybody else. Maintaining that impartiality of health workers is a big challenge. And so this, I think, COVID basically gives us an opportunity again, right? What COVID is showing is that if we don't care of our health workers, this pandemic will never be solved. So, and I think we should do that. Now, frankly, it's a challenge in the coming months with vaccines coming in. Because remember, with vaccines, limited vaccines, everybody, well, not everybody, very significant number of people fighting for that. Now, well, our friends from WHO, sorry if WHO is here, would say, we have a prioritization, allocation, all of that, let's follow that. Come on, when you go to the ground, it's a different story. You could not use this government guideline and say, oh, by the way, you're 59, you won't get it. Your neighbor who is 60 will get it. Come on, you're a little bit obese, you won't get it. This guy, it's that kind of issues will start cropping up. Yes. Health workers, what is a health worker? You are a community health worker. You're not an official paid government health worker. You're out. You don't have a health degree. You're out. So, and you could imagine people then attacking the health workers. So we need to address that. We need to face this. I know this is not a vaccine conference. I'm sorry, I've been in too much vaccine work in the past few weeks, but I think I would call on EYAPO to start and really reflect on this. We need to do the prioritization, but we need to be more savvy than just expect health workers priority and expect the whole world to follow.
Thank you. Thank you very much. That was all we had. If you can wrap up the session, that would be great. Thank you very much.
Right. I mean, it's a difficult session to wrap up, but I think what I hear is that we are really some way off from community participation on all fronts, really. We have a long way to go. And I like Dr. Eduardo's example of vaccine, because we have been having so much of misgivings within the country about who should get the vaccine. And it's bringing out in sharp focus how communities are really not being taken along, and different statements are being made about who should get it and how, and whether everyone should get it, etc. Clearly, it's a rationing thing. And when there is rationing involved in any product or service, you really need to know the principle that you're following for rationing. And the principles have to be made very clear up front, which has not been done. And the way it can is by taking the community into confidence. All about you. So can we have your views on who should be getting vaccinated? Maybe they'll come up with an algorithm that is going to be agreeable to all of them, all of us. But that has not been done, and it's about time that somebody thought about it. So anyway, with those words, I think I would like to thank each and every one of you for a wonderful session, and hope that APPC can take this agenda forward and really get communities to get involved in the UHC agenda. Thank you very much.
Thank you very much.
Bye-bye.
Thank you. Bye-bye. Thank you.
Bye. Thank you.
Bye.